My theory is acute pain management, and jumping right into the meta paradigms. Pain can affect everyone differently. Good and Morris describe pain as an intense discomfort that can delay healing and recovery in patients. Environment. Creating an environment that involves the patient in their care can also aid in pain management, along with providing a quiet, peaceful environment. With health, everyone has a different tolerance to pain, and as always, pain is very subjective to what the patient states that their pain is. Nursing, Good discusses three propositions that predict a good balance. So these three things are multimodal interventions, attentive pain management, and patient participation. So with the multimodal intervention, this is a potent medication, plus pharmacologic, and then plus non-pharmacologic methods. So this would be more so, maybe for an example, morphine with a muscle relaxer like Robaxin, and then maybe providing some ice or heat to the area. Attentive pain management, so this is the reassessing of pain by the nurse, making sure that these medications are, providing that pain management, but also not causing side effects for the patient. With patient participation, this is setting goals for pain. So if our patient is stating their pain is a 10 out of 10, we're hoping that after providing this pain intervention, that it kind of goes down some, maybe a 7 or 6 out of 10. So currently I work on a post-operative med-surg unit, and generally our patients are admitted to our floor after abdominal surgeries, orthopedic surgeries, or any traumas. So acute pain management fits really well into my practice setting. Many of my patients, my surgery patients, have standing orders to ambulate 4 hours post-op. So on post-op day 1, these patients are expected to ambulate 3 times a day in the hall, and up to the chair with each meal. So managing their pain is the only way we're going to get them active in their recovery. So 2 examples, let's say we have a colon resection patient post-op day 1 with a midline incision. So we all know how much we use that abdomen to get moving, just to sit up in the bed even. So the multimodal intervention directly affects patient's care because it allows the patient to have the option for Dilaudid, right before physical therapy works with them, and then also maybe 2 hours later have that scheduled Robaxin. So this allows a rapid pain relief along with maintenance measures for the patient. A second example is a patient that is in severe pain receiving Dilaudid every 3 hours, but is having some nausea and vomiting, after getting that Dilaudid. So if the patient has an abdominal incision, this is creating more pain for the patient from the pressure that's being put there from the vomiting. So by the nurse being attentive and reassessing for pain and those side effects of the medications, she can call the physician and possibly change out the medication. So commonly on our unit, if patients are not tolerating the Dilaudid, maybe we'll switch them to morphine, or we can just simply change the dose that they're receiving. So those are just 2 examples that the multimodal intervention is actually being used, and also the attentive pain management with our patients.